Hello. Looking rough this afternoon. Totally unfiltered face here. You're welcome. You're welcome. Um, so hey everybody, hey, if you're just stumbling upon this and we haven't met yet, my name is Bree. I am an ICU nurse practitioner and I get ready weekly for a night shift. And typically I'm putting on makeup and talking about all the things. Sometimes it's educational, sometimes, hey, Mr. Midwife. Sometimes it's educational, sometimes it's professional. And this week I'm talking about COPD and why the labs are weird, and also a little bit of background on Fishbones and how to use Fishbones. So I'm not getting ready this week. It's kind of weird, but my work week this week has been shifted back. So I am not working tonight. That's good. The negative is you're now catching me 2 days post. Well, this last night was my second night, which is usually never good because I don't sleep during the day. So you got night shift brain, but I'm gonna impress you with how I'm gonna pull it out. Um, maybe I'll wait and ask the question later on when a few more people jump in here. But yeah, I don't have makeup to distract you today. So you just got to see the unfiltered face and we'll just, I guess, dive right into some educational stuff. And I'm about to wow you. I mean, I'm going to wow you with my technical savviness because I don't use like a live stream or a streaming platform. So I needed to upload some pictures and I don't know how to do that if you don't use a streaming platform. So I'm literally just going to hold stuff up in front of the camera. Old school style, old school. All right. So COPD, I have talked about this a lot, and it is one of my favorite things to talk about. Not necessarily COPD, but just because this particular state, this is a chronic illness, and I am fascinated by the infinitely wise body and how perfectly we were created to compensate for when things are bad. And you see this very commonly in people who have chronic diseases that they're living with, like heart failure is an example. And COPD is one of those that to me is a little bit less complex and kind of easier to understand. So they will have very abnormal looking labs, but it's normal for them. And if you fail to recognize that when you're looking at these abnormal labs and you see red numbers show up, your instinct is to try and make them black again. You want to fix them. But that's not normal for them because their body has adapted and changed. So if you try and make them normal, you actually make them abnormal. I just love this. I love this. It's just I get a little nerdy on this kind of thing, but it really excites me a little. The other thing is the other reason I talk about this a lot is I work in an ICU. So in the hospital, I get calls a lot for people that somebody thinks that their COPD has gotten worse and they need to go on BiPAP and they're basing it off of an ABG. And I caution you to try and have a deeper understanding of what the numbers mean and how to put that in context with how a patient looks before you just put them on BiPAP. So we'll get into some of that as well on here. So we can't talk about this until we talk about the value of Fishbones. Fishbones, okay, let's see how this is going to work out. This is going to be high tech, y'all. Fishbones are basically a set of, it's a sketch. Let me just show you. Okay. Oh, God. So, yeah, this is working out. Okay, those are Fishbones. So, you don't need to see her, do you? This is from my blog post. Sorry. These are Fishbones. These are basically just sketched out little things here. I don't know what the word is because again, night shift brain. But these are a universal language and a way for you to record your labs. It makes it quicker for you. You just write everything down very, very quick, like rather than writing out K and then the number and NA and the number, which is what I see. I would probably say 90% of nurses do. And that is one of the first things when NP students come and do preceptorships with me. That is the first thing we work on. You got to get rid of this mentality because you've got to work faster. And the other benefit of this is it is universal language. So if this is written on your paper and your attending or somebody wants to know, hey, what is this? You just hold it up and they can look at it and very, very quickly interpret it. So this would be your CMP. So sodium over potassium, chloride, CO2, BU, and creatinine, glucose. This is your LFTs, This is your calcium mag phos. So this would be BMP. That's what's on the CMP, the complete metabolic panel. This is your coags there, and this is your CBC. So I highly encourage you, if you're not already doing that, to start doing that. And it's really, really not hard to learn. If you download like a copy like this, where you have the grayed out values behind it, and just start putting them in that spot, like you do it 2 or 3 times, and your brain just starts. You have muscle memory, and it's super easy. So I am a big fan of Fishbones. And I had to give you that preface because I'm going to show you what you will typically see on a patient with chronic COPD, someone who's had COPD for a while, that the body has said, okay, we need to compensate for this and fix it. Okay. So this is your BMP. Your chloride will be low, your CO2 will be high, and on your blood gas, your pH, this is for chronic COPD, will be normal, and your PCO2 will be high, could potentially be very, very high. So that's what you tend to see. And people, let me tell you what, this number right here, this PCO2 is what freaks everybody out. Every time you get a red number there, even if it's only marginally red, everybody wigs out. They want to do something to help this person breathe, help them ventilate, and don't do it. Not just based on that number. I don't feel like anything that we do in medicine should be based off of a number. You need to have clinical context with that number. Take a page from the radiologist note that says, recommend clinical correlation. Yes, this is what I see, but is that what's happening in reality? Always, always clinically correlate before you just treat someone based on a number. The pollen here is so bad, y'all. I'm in Georgia, and why in the world are we having spring in February? It's super weird. Super, super weird. But because I have terrible allergies, you're going to hear me coughing throughout this. Yet another benefit you get to joining me today. Thank you so much. Okay. Also, if anybody has any questions or anything else they want to talk about, unrelated to this even, by all means, jump in. I am an open book. So let's talk about why these numbers are abnormal, when you need to be concerned about them, and when you don't need to be concerned about them, and when you just need to leave them alone. I think I started this blog post out talking about how we need to go back to the roots of what our initial pledge is to our patients, and that is to do no harm. So you have to understand what the abnormals are in order to just let them take care of themselves. So don't do harm, but you have to understand the physiology in order to not do harm sometimes. So the chronic COPD, or the PCO, it starts with a PCO2. So with the physiology of this dead parenchyma, COPD, chronic obstructive pulmonary disease, is when you have non-functional units in the lung. So on imaging, particularly CT imaging, it looks like Swiss cheese holes in the lungs. So there are pockets in the lung that have no alveoli, no tissue to perform the act of gas exchange. Oxygen's not getting in, CO2 is not getting out. And these people end up developing a lot of retained intrathoracic pressures. And it's mostly because the collapsed alveoli on top of the damaged airways themselves, you have more of an obstructive problem in getting the carbon dioxide out. So the carbon dioxide level builds up in the bloodstream, and you develop a respiratory acidosis. So you're going to have elevated CO2, PCO2 on your ABG. Now, before I go any further, we need to take a minute and clear up something. And this took me way longer than I want to admit to you before I kind of fully understood. I don't think my entire nursing career I really understood this, but medicine is just like super confusing. We like to keep it that way. I don't know why. I actually know why this problem exists, and it is a lab issue. But there are 2 values that you will see on labs that say CO2. The PaCO2 on the ABG and the CO2 on the BMP. Let me go back to that Fishbones. So this one, let's see if I can put my finger there and it'll show up. Okay, here, this is going to read CO2, but the ABG is also going to read CO2. So they should be the same thing, right? They're both carbon dioxide. Not really, because it's got to be clear as mud, right? The PaCO2 on the ABG is the partial pressure of carbon dioxide in the arterial blood. This is controlled by the lungs. The CO2 on the CMP, this is a total blood carbon dioxide level. And total serum blood carbon dioxide is comprised of 95% bicarb, which is HCO3 negative. Do I have that written out here? I don't. Okay. Anyways, CO2 in the bloodstream is total CO2, 95% bicarb. The other 5% is like carbonic acid and dissolved, and then the other portion is dissolved carbon dioxide. So it is overwhelmingly bicarb. So this is a measure of bicarb. It just reads CO2, even though only 5% of that is actual CO2. It's because of the way labs are processed. So labs have driven this. It it just it's irritating because we could simplify things for the people who are doing the work and interpreting the labs, and it would make life a whole lot easier for everybody involved. However, it is what it is. Mr. Midwife, you are watching with only one eye. What happened to your other eye? I'm sorry to hear that. I will pray for your eyes. It didn't sound good. Is it swollen up from the pollen, like my throat is? um, all right, so that's the difference between CO2 and bicarb. Now, on the ABG, when you get an ABG result, you'll have the pH, you'll have the PaCO2, you'll have the PO2, and then you'll have HCO3 or bicarb. That is your arterial bicarb. That is not a real number in most labs. So essentially, you cannot measure both CO2 and bicarb in the arterial blood. One of those numbers is going to be a calculated derived number based on the other one. I'm not going to get into the whole whys of that because it goes into physiology stuff and calculations that are just super complicated, and I don't think necessary to understand. Just understand that when you get an ABG, one of those two numbers is calculated, and it's most always, from what I've seen in practice, it is the bicarb, and it is calculated based on the Henderson and Hasselbalch equation of compensation, and it's not the actual bicarb level in the serum. Now, it's pretty, I've seen a lot of studies that show that it correlates pretty well. But it's not the actual number. So it's off by, I wrote it down, I forgot. The true bicarb level in the serum is slightly higher than the calculated number. So the bicarb you'll see on the ABG is a little bit less than what is actually happening in the bloodstream. So you could convert it and just add more to it, but I would prefer personally, especially if I have a metabolic panel, to just look at the bicarb level in the serum. That's an actual measure of what's happening in their body. So when you're looking at someone to determine whether or not this person is compensating for acidosis or alkalosis, you want to look at the CO2, PaCO2 on the ABG and the bicarb or the CO2 on the CMP. Yin and yang, because one buffers the other. One is acid and one is base. Okay, so that's a little bit of the background. Then, so back to the pathophysiology with COPD. So the pulmonary system is not able to expel carbon dioxide level. So on your ABG, the PCO2 number will be high. And depending on the phase of chronicity and severity that this patient is in for their COPD, it could be super duper high. I mean, you will see numbers quite often in the hospital that aren't even registered. I think most blood gas analyzers will go up to like 99 or 100, and then it'll just say greater than. So who knows how high it actually is going. But in reality, I think that for like the patient that we're talking about, like the stable kind of compensated patient at home with chronic levels, they're going to be in that 50 to as high as like 70 or 80 range. The PCO2 will be. But what's more important, this does reflect respiratory acidosis. But if you go back to ABG interpretation basics, if the pH is not low, then it's compensated. So the acidosis has been buffered, and now the pH is normal. So this reflects an alteration of their physiology to compensate for all that retained carbon dioxide, which is just fascinating to me. So wise, so smart our bodies are. So the way that our body buffers out and compensates, well, it does several things, but um, it is going to do multiple different pathways in order to compensate for that respiratory acidosis that will be reflected in your blood, your serum levels of chloride. So we'll talk about that in just a second. Um, After 2 days of night shift, it's like, come on, synapses, let's fire. So let me just harp for just one more minute on the elevated PCO2 because this is something that I see all the time, and this is kind of going back to that clinical correlation thing. If your PCO2 is elevated on labs, everything's red, but your pH is normal, I would probably also look at the BMP first, but at that same time, I'm looking at the patient because if the patient is not reflecting that they are hypercarbic, if they're not in a coma, if they're awake, if they're not confused, if they don't have a high work of breathing, they are they're compensated. This is their normal state. Don't put them on BiPAP. Don't tell me we need to intubate them. Just because the PCO2 is high does not mean that they're not handling it just fine. You have to put them in context. Now, if you get an ABG and the PCO2 is like greater than 100 and the pH is 7.1, and you go in there to look at them and they're a little bit confused and they're working hard, they've got a lot of abdominal accessory muscle use, they're tripoding, yeah, absolutely. This patient is in decompensated COPD and they need ventilatory support. Absolutely. But those are two very different people. So this is my caution with the just looking at the labs and interpreting or basing a plan of care on a number. Okay, I think I've harped on that plenty enough. Lecture complete. Check. Um, clearly, this happens all the time. I'm standing on ceremony here, y'all. Now, so that's the other thing that is normal, that is normally abnormal in these patients, and that is you will have a high CO2 with a normal pH, which doesn't really match, right? They don't really match. Then in the serum, the way that the body starts to compensate for this is by producing more bicarb. So there are a couple pathways with this, one of which is there are things that the kidneys do. So a lot of things that the kidneys do. So if you have a patient that has chronic COPD and they have renal failure, be very afraid because at some point in time, the kidneys are going to stop doing what they need to do to help out the lungs. Kidneys and the lungs, yin and yang. But we'll get to that in a minute. The first thing I want to talk about is buffering. So you're going to, let's see, intracellular and extracellular shifting of bicarb to buffer that acidosis. Your body is going to start pulling bicarb out of the cells and putting it into the bloodstream. Bicarb is negatively charged. So your bicarb levels on the CO2 on your BMP or CMP, this one, okay, are going to be high because the body is trying to produce more bicarb to buffer out the acid. So this is high. Because it is a negative charge and our cells are super picky, very OCD, they like everything to be, electrically neutral. Gotta have, if a negative comes out, a negative's got to go in. So guess which negative ion goes in the cell? The one that's low, your chloride. So your chloride level will be low, but it's really not truly low. It's just pseudo low. So you have low chloride, high CO2. This is classic for a chronic COPDer. So you get a normal pH, high PCO2, elevated CO2 on your CMP, and a low chloride. And you go in and you look at them, and they look kind of okay. Okay, that's normal for them. So the other way that it's going to buffer, okay, so this is the intracellular extracellular shift. Then you're also going to have your kidneys kick in, and they are going to hang on to bicarb. So it's going to retain it. It's not going to excrete as much of the bicarb. So that's another way that it raises the bicarb level. It's also going to excrete carbon dioxide, CO2, in the form of carbonic acid. So remember when I told you that the CO2 on your BMP is actually bicarb, and it is total body carbon dioxide, which is 95% bicarb, and the other 5% is composed of carbonic acid and carbon dioxide. That's the piece of the bicarb, which is actual CO2 that is being excreted. So that's how the kidneys are helping you to deal with this chronic state of acidosis. So that's going to lead to a net effect of a increase in that CO2 on your BMP. And so you have a fully compensated state. This is normal. This is status quo. This is what we want. We don't want to tweak these numbers. This is normal for this person. So then the question is, when would you get to a state where this would be abnormal? And when would you intervene with this patient? Well, this, I kind of already alluded to it, and that is when you have the acidosis. So when the pH starts to drop and the patient looks bad, that's classically when you're going to start to ventilate for this patient. The other thing is when you have increased respiratory drive. So the chronic COPD tends to be very anxious. It's like having a rubber band around your chest. You take a deep breath in, exhale half of that volume, and then keep the other half, and then breathe on top of that. And that's how they're breathing. They have like this like constricted feeling of not being able to get air in or out. And so they are profoundly sensitive to, I mean, they're anxious, right? Living your entire life not feeling like you can take a deep breath, I would be anxious too. So they're very, very sensitive to states in which this compensation goes away. So tachypnea is something we see very, very commonly. So if something tips that anxiety scale over the edge and they become tachypnic because of anxiety or sepsis, which is very common. In sepsis, you start developing a metabolic acidosis and the body compensates with a respiratory alkalosis, which is the exact opposite of what these people are doing. But if it becomes too much, then they tip over the scales and they can't keep up. So that's a state in which tachypnea will develop, and they do not have the functional reserve to handle tachypnea. These are the people that do really, really well with Precedex and BiPAP. It's a beautiful thing. If you can slow the respiratory rate down, give them a couple hours on bicarb, do not recheck an ABG within an hour, at least a couple of hours I give them, and I also watch them really, really closely. But quite often people will slap someone on a BiPAP and then immediately get an ABG like within 30 minutes or an hour, and it's unchanged or marginally better. And they're like, time to tube. Just give them a little bit. It takes a little bit more time than that. The respiratory compensation is much, much faster than the kidney compensation is, but it still takes a little bit of time. So that's one situation. The other situation that COPDers get into trouble with is because they're anxious, they're on a lot of medications at baseline. They are almost always on some type of benzo, and a lot of them are on opioids as well. And this combination in particular sets people up for apnea, for slow respiratory rate, which in some respects is good for these people. We've on a long E time, a long exhalation time. But when it dips too long, then they don't have the respiratory acidosis worsens, and they don't have enough time to that CO2 rises more and more, and then they tip over the scales. So over sedation, and you never know at what point in time these people are going to become over sedated. It's just going to make it worse. It's going to worsen the respiratory acidosis. Neuro injuries would do the same thing. Overdose, you know. And any situation in which the alveolar or the base functional unit of the lung is compromised, kind of tips them over the scale as well. PE would be a classic example of that. So those are the situations in which you want to be a little bit more weary or leery that it's going to become really bad. You have to do something. Comorbidities that can also set you up to, I don't know that it would be like an acute situation, but say you were managing this patient outpatient. The patient you want to keep a closer eye on is going to be, as I alluded to earlier, the person who has bad renal failure, or as the renal failure is progressing and maybe it gets to a point of ESRD because you're not getting that kidney compensation anymore. Heart failure. So heart failure is a prognostic indicator of advancing COPD levels. Yeah. Because in COPD, You develop basically a chronic state of pulmonary hypertension. So you don't get good blood flow to the lungs. And then anything that worsens that forward flow, that right heart flow, anything that tips over the scale, like a PE, then they're going to struggle even more to get the blood over there. And when the blood gets over there to the lungs, it's not able to participate much in gas exchange. So you're just compounding the problem. So the acidosis is probably going to get worse. They'll probably also become hypoxic at that point too. And then eventually that'll lead to left heart failure. And eventually these people will develop cor pulmonale, and that's end stage for sure. I already talked about anxiety was another thing that will do that, and sedatives. One other thing I wanted to talk about in regards to this Fishbones. Another patient that you will see this constellation, so ignore the ABG for a minute, just look at this section. These two, where the chloride is down and the CO2 is up. Another state that can lead to this that we commonly see in the hospital is a contraction alkalosis. This is the patient who has diarrhea or is over-diuresed. So they're losing a lot of volume. They're losing chloride in the kidneys are excreting chloride. This is a situation in which giving this patient volume back, particularly chloride-rich fluids like NS or LR, will fix this problem and change those labs. But this is different than our chronic COPD because the chronic COPD doesn't actually have a low chloride level. The chloride is just hanging out inside the cells. It's a pseudo low chloride. So giving a COPD or volume because you think it could be contraction alkalosis isn't going to help them because it's not actually volume loss. It's not actually low chloride. Versus like if it is a patient that has a ton of diarrhea or that you diurese the heck out of for 3 days, if you could attribute this to like a chronic COPD state, you're missing out on an opportunity to optimize that patient. So you determine the difference between the two by sending a urine by looking at the history, like have you been given diuretics? Have they been having diarrhea? Do they look like a COPD? Like clinical correlation always, but send a urine chloride level. Okay, and if the urine chloride level, I have to look this up every time because I can't remember it, y'all. Because it's sort of I don't know, it's one of those like negative feedback kind of things, which I always have to really, really think through. With a, okay, if the urine chloride is less than 10, if it is low, yes, if it is low, then you will have a contraction alkalosis, and this patient may respond to fluids. So try giving them some fluids. So less than 10 is what I have written down. If it is greater than 20, I've seen 40 in other lab reports though. If it's high, or even maybe normal, if it's like that upper 20 range, it's probably not a contraction alkalosis. Giving fluids is just going to be suboptimal, or at worst, if they're heart failure or something like that, could make them worse. So check a urine chloride level. And that is it. That is it, my friends. That's all I have on that. I just think it's really interesting because I don't know, it's just such a beautiful pattern of how our body learns to deal with badness. I don't really have much else educationally. I don't know how many people are on here right now. Mr. Midwife, are you doing any conferences this year? I was going to go to a Northwest seminar in Montana, critical care conference, which I've gone to before and I really like, but it is super duper expensive to go to Montana. Like my CME is only going to cover just the stay, just where we're going to be at. And right now I just don't have like $4,000 or $5,000 to spend on a trip. No conferences. I think that, so I'm pretty sure I'm going to cancel it. And I've been looking instead at going to AANP, which I am not an AANP member. I guess I'm gonna have to become a member before I can go, but there's one in New Orleans in June. And I've never been to like an NP specific, like professional conference. So I think I'm going to try that this year. Money issues just impact everything, does it not? When the hospital only gives you $2,500, it only takes you so far. Montana not included. That's on the bucket list though one day. We've been watching Yellowstone, of course, so I'm like, Montana sounds great. um, yeah, so I think I'm gonna do the AANP thing, but I've never done it, and it's a little bit like overwhelming for me to think about because it's such a huge conference. It's at like the like a big conference center, and it's a bunch of breakout sessions, and so I'm like on Facebook, like asking all my friends, who's gonna go? I'm a joiner. I need someone to go with me. So if you're interested in AANP, jump on in. They did have, I was trying to think, I think they had some women's health stuff, but I don't remember if I saw midwifery specific topics, but I'm thinking that's what I'm gonna do. And there's not really much else going on in my life right now. My birthday is Saturday, and I am lucky for my birthday this year. I will be off work for 6 days. Yay, me! My friend at work last night said, "What are you doing for your birthday?" I was like, "I'm going out to dinner, and I'm not working." Our value on what is fun for our birthdays definitely changes as we age. Just having all my kids home, sound like a grandma, but I do have a thank you. I do have a daughter that's in college, so when she's home, it's always delightful. So I'm looking forward to that this weekend, and I think the rest of the day I'm just gonna recover today. Usually my post-call days, like, I'll wake up around, anywhere between 11:30 and 1, and I got, like, a maybe functional 6 hours, and then I'm going right back to bed. It's a total waste of a day. So I'm sorry you're not getting the best version of me today. I know, I do look great for 20 something. I mean, I am self-preserved with Botox and all the things. I mean, these days we can be 95 and look like we're 25. Or some of the patients I see in the hospital are 42 and look like they're 75. I'm like, wait, she's making me feel a little bit better about myself. But just avoid the meth and cigarette smoking and you'll be just fine. Early use of Botox is what my plastic surgeon says. I didn't know there was such a thing as preventative medicine with Botox. She's like, you should start early to prevent. I was like, to prevent what? Prevent the wrinkles, dummy. I didn't know it worked like that. Apparently it does. Yeah, so that's all I got. I think for next week, what was it? Oh, decision fatigue. So one of my workmates said, you really should talk about decision fatigue because that is something I underestimated as a new NP. And I would agree with that. That is one of the things that truly uh, I underestimated and made the onboarding so much harder. I don't think I don't know, maybe they told us in school how bad it would be, but I don't remember truly appreciating it. Hey, Scott. Well, you came in at the very end. We talked about COPD and how the labs compensate for it and Fishbones and whatnot. Um, so if you're interested in that, go back and watch it on the replay. Um, did you bring it up from your mother? Is your mom okay? Scott is an FNP student right now trying to a note. I'm not following you. I hope everything's okay. I don't know, y'all. My synapses aren't firing well today. It's day. I don't even know what day of the week it is either. But we were just talking about my plan for next week. I was going to talk about decision fatigue, which is something that made it very challenging when I was a new NP. I remember thinking part of the reason why I left the bedside was I was always so tired after I worked a bunch of shifts in a row, physically like just drained and my back would hurt. And that kind of went away, but then your brain hurts. Your brain hurts as a new NP and it hurts for a long time. And you have no, like, you just don't even realize you'll do a stretch of 3 12s and the fourth day you will still have to lay on the couch and just watch Netflix and sleep and cry and try and recover. And it's because your brain hurts. So the decision fatigue is what does it to you as an NP versus the physical fatigue. He's asking if I brought a note from my mother for being late. Of course he is. Very clever. I love it. Okay, so I don't have anything else. This is kind of a short one today because Scott, I was saying that I am not working tonight because my work week shifted. So there's no makeup application today. Today is recovery day. This is why I often don't join Liz's live streams because it is very hard to think on this day. I don't know how people do full-time nights. Like, I do usually 2 nights a week, and I the recovery is it's rough. It starts at around 4 AM from last night. I would say if you're a patient in the hospital and something bad happens to you at 4 AM, call the cavalry because usually, if we show up at the bedside, I'm like, "I don't know. I don't know what's wrong with them." I truly don't know. I cannot form thoughts. Um, I think it's partly because I can't sleep during the day. So I'm really just kinda running on, coffee and Adderall, and once that wears off, there's not a lot of functionality left. 802 Merce says, "Recovery on anything over 2, not" yeah, for sure. It's so bad. I my friend that I work with, takes a sleep aid, and she'll sleep, like, 8 hours, and she just rocks it. And then one of the guys I work with can sleep no problems. Like, he just I don't know, it doesn't matter how tired I am, there's something in my brain that says, "It's daytime, and we must wake up." And our doctors will do 7 on, 7 off, which I forget it. I would quit. I will never do 7 nights. Never. I can barely do 3. 2 is getting a little rough. However, I have blackout. I do. I have blackouts and I take like this really thin t-shirt, black t-shirt, and put it over my eyes. So it is black. Everything is black. It is not the light. It is something inside my body that says, wake up, girl. There's too much to do. The day is getting away from you. um, Nights, you know what I do love about nights though, is that the BS is not there. Like you go into work, everybody's happy to be there. We work as a team. There's no like administrative hierarchy, like just crap. There's none of that. Yeah, it's admin. And I mean, I always remember when I was a bedside nurse, I never worked nights. I do remember the nurses saying that and how nice it was, but I really kind of thought they just meant like, okay, there's no directors there. There's not all the ancillary staff there telling you what to do. You can just kind of let your patients rest. But I think from a provider standpoint, the difference is that there I mean, I'm just gonna say it, there are less physicians there. There are, I have to think how much I wanna say publicly, but you get my drift, right? There are less people there that may not appreciate the interaction between APPs and physicians. So, typically, at night, doctors like to sleep, so they are more than happy to let you practice. It's this phenomenon of, "You are a fabulous provider at night, and during the day, I do a better job than you do." I know, you know, it's just so that's why it's delightful at nights, and kinda where I'm at in my career, there have been a lot of changes, and so it's really nice to not be involved in all that, like, just drama. Just come to work, we're gonna work as a team, I trust what you're doing, and take care of the patients, and I like it. I definitely like it. It's just that 3 to 5 AM time frame, like, if you can survive that phase of hell, then the rest of the time is great. And you can actually get stuff done during the day, you know, like, I mean, you might be tired, but you can physically take a kid to school or go to the grocery store. Although when I walk around the grocery store on a post night shift, I'm like, yeah, that looks good. That looks good too. I, I way overspend and make poor choices. It's a compensation, but maybe not so healthy. I don't know. I used to do really good about getting up and hiking for a couple of hours, and I sort of have segued away from that because I hurt my knee last summer. That in combination with I've been, like, rapidly trying to grow my business, so my focus hasn't been so much on that. It's hard for me to, like, dedicate a couple of hours to going out in the woods and hiking, and my husband's like, "Well, just go for a quick little walk around the neighborhood." I'm like, "That it doesn't work the same to me." Like, this is how I ground. This is how I recover and just, like, wash out all the, like, trauma and exhaustion is walking in the woods. And I do not get the same thing if I'm walking on concrete. I don't know why. I don't know why. Thank you. My husband said, "Where is this from? Is this a place we know?" And I was like, "I have no idea. I don't even know if it's in this country. I just saw it online and I was like, oh, it looks nice." It's the earth connection. That's right. It's grounding. I carry my magic rocks, as my husband calls them. I put my grounding rocks in my pocket and I go out in the woods and I listen to a podcast and life just fades away. And so I'm talking about it. So therefore, it must be a subconscious thing. I clearly need to get back into it. I just hope that the knee will hold out because, in true nursing fashion, I'm pretending like nothing is happening and I have not had an MRI or pursued anything because if you ignore it, it'll go away. That's my theory, at least. Um, I don't know. I do need to get back to it. Um, where I'm at in Georgia, we're really lucky because we are at the tip of the Appalachian Trail. So there's a lot of really great hiking. Now I have to drive probably a good like hour away to actually hit the AT, but even around here, there's a lot of like ridges and there's just a lot of mountainscape here. It's not as intense as the AT, but it's very, very nice here. That is one thing I do like about Georgia. We get 4 seasons and we have really good topography here. The body will heal itself, but if there's something to be repaired, you should get it that figured out. I know, I know, I know. It's very true. It's very true. My plan is to just restart slowly and see how things go. I when I injured it last year too, I was also doing really heavy hiking. Like I was hiking twice a day sometimes. I was just overdoing it. So I'm hoping that dialing back and resting it some will have repaired itself. We'll see. We'll see. I don't know. This is the beauty of aging. We were talking earlier, Scott, that I turned 46 this Saturday, and my friend at work is like, "What are you gonna do for your birthday?" I'm like, "I'm going out to dinner." Like, I don't know. This is how we celebrate a birthday at 46. Like, I have 6 days off of work. I can't remember the last time I had 6 days off of work, and I'm going out to dinner. Like, it sounds absolutely divine. Oh my gosh, yes. Knees are and probably joints. I know, they're terribly and part of my issue was I was a long distance runner from the age of 11 when I was probably too young to be doing it, and DJD runs in my family, and so I just pounded them into the ground. And so then in college, when I was training, like, for marathons, I they just shut down. So running is out. I swam for a couple years. I love to swim, but that makes my hair break and fall out, and I'm too vain for that. So then I kinda segued into hiking, and that's what I've done probably the last decade or so, and I do enjoy it, so I'm gonna get back to it. Um, you never ever work the birthday week. I know, I've never taken a whole week off for my birthday. This kinda just and I didn't plan it this way, it just worked out this way. I did request my birthday off, because I worked 1 year on my birthday and it was horrible. It's really horrible. It's depressing. So, I won't ever do that again. But yeah, 6 days off. And I tend to work a lot of well, not a lot, a fair amount of overtime, but I'm not doing it this week. Happy birthday, no overtime. Um, yeah, so that's that. I don't have much else to really report on here. Oh, I do have something else to share. And always a gong show. Yes, self-care, I like it. I quit having birthdays, so I work all the time. Mr. Midwife, we need to talk about this. Okay, this is worse self-care than me ignoring what's wrong with my body. Um, I think we're all a little bit workaholics, aren't we? That's probably why you joined this. We're all kind of the same person. Um, oh, this is the other thing I was gonna tell y'all because I love to share when things have changed my life. Typically, it's in the form of products or makeup, but this might be relevant to y'all. I am on a couple of Facebook forums for NPs, and one of them is actually for travel NPs because when I got mad, I can't go into big details here publicly, but I okay, I'm a job hopper, and whenever I get frustrated, I'm like, "Peace out, I'm finding something new." Last fall, I was convinced that I was gonna quit my job and become a locums NP, which I still part of me still kinda has that, like, drive to do it, but ultimately, I decided I've got 3 kids and aging parents, and they all live here, and, it's where I'm at in life. But anyways, I went down a whole rabbit hole because I got ADD, so I get, like, obsessive, and I did some major research on how to be a 1099 contractor and all the things, and I found a forum that is specific for locums NP providers, and on there, somebody was talking about how to do your taxes, how to write off all the stuff, and the financial benefit of being 1099. Which I've been 1099 before in the past, but it wasn't like anything big. Like I just did temporary jobs and it was never really enough money to really use to write anything off. But if you're full time, like 1099, the amount of stuff you can write off is insane. You can bring your probably very high salary down to a lower tax bracket. And it's kind of complicated to me. So on this forum, they were talking about all these things you can do to write off if you are a travel locums and if you have an LLC, which I do have an LLC. So in there, they recommended somebody was asking about an accountant, and somebody recommended an accountant that they use as a travel nurse who saved them a ton of money. So she happens to be here in Atlanta, and I went to meet her this week. And holy cow, y'all, worth her weight in gold. I probably afterwards will put a link to her down below because I think she does actually, I think she does most of her stuff virtually. I was in her office yesterday for like 2 hours, and she said it was they had just started having clients come back to the office. So I think she could do it all online. Scott says mango juice. Yes, fish mango juice. If you need your fish oil, take it in the form of mango cream. Yeah, nobody else knows what we're talking about, Scott, probably but okay. Anyways, I like to share products. I just do. I like to share things. If you would be so kind as to send me the link to that Facebook, I will absolutely. I'll put the link to the Facebook group down below, and I'll put the link to the accountant down below because I'm pretty sure she does remote stuff. But a little bit of background here. My husband and I have rather complex taxes because he does work out of a home office. And for many years in Georgia, you can write off a lot of stuff with a home office. So every year I had to prepare all the things, all of our bills, all of our expenses, and then take it to an accountant and have them do it. And we've used the same guy for probably a decade. And then because I saw this girl recommended, I was like, you know what? Maybe it's time to change it up and see somebody new who kind of understands the realm. Because last year, so 2021 taxes, I launched my business. I started making income from this kind of thing November of 2021. So I only had like 2 months of income. But my previous accountant, I went to him and had all these questions about because then it gets really, really complicated, right? Like, are we writing stuff off for John's office? Are we writing it off for my office? What can I write off for the LLC and not? I don't know this kind of stuff, right? And this accountant was kind of helpful and kind of not. So, anyways, jump to the end, Brianna. I went to this new accountant and holy crap, not only does she know nursing stuff, and she's used to doing taxes for 1099 nurses and can come up with some of the most creative things in the world to write off. She also is kind of venturing into the social media platforms. So she knows what is okay and what is not okay to write off if you happen to be an influencer. And she specializes in small business. So she's like perfect. She's like the unicorn for me. And let me tell y'all the difference. Okay. Let me tell you the difference because our goal as a couple has always been to net even, like just get as close to owing nothing but getting no return as possible. I know the gurus will all tell you you actually want to owe a whole lot because that means you've hung on to your money all year. But if you're not the kind of person who's going to be smart about like looking at the numbers and having a great plan as far as what you're doing with that money, investing it, then especially if you're the kind of person who's just spending it, then you're screwed at the end of the year. We're not like that, but at the same time, I don't like the pressure of feeling like, oh my God, we're going to owe like 15 to $30,000. I can't live like that. It's too much anxiety for me that I already have. So we strive for net even. Typically, we'll get like a grand to 5 grand back. But from 2021, we ended up owing 5,000. It's the first time we've ever owed, and it was not a happy place for me. I don't like it. It made me really stressed out. So anyways, we paid that off. And then this girl, so 2022 returns, I'm gonna get $10,000 back. We have never in our lives gotten that much back on our returns. Not that I really want it to be that way or planned it to be that way, but there were so many deductions I was able to take from the business, and technically the business was a loss, technically. Um, oh my God. Oh my God. It's amazing. I don't even know how much she costs because she hasn't sent me the invoice yet. And I was like, I don't care what it is. She's worth it. So I'll put her link down below too if you're interested in that. But thank God our tax thing. I hate tax season. It stresses me out so bad. When I make it big, and I'm actually in the red instead of the black at the end of the year, that's the first person I'm hiring is someone to do the books because I don't like dealing with that stuff. You got $18. That is perfect. Scott said he got $18 back this year. Totally different circumstances. Well, sure. But again, the goal is, keep your money as long as possible, let it work for you instead of the government, and then get nothing back. So we've never actually gotten that close to zero. That's kudos to you. I think that's perfect. So that has been my week. Tax hell and figuring out what fabulous restaurant we're going to go to for my birthday. And I don't know. What am I going to do for 6 days off? Maybe I'll get back into hiking. Clearly, that's what I should do. Single trip to Starbucks. Exactly. So that's a Vinny extra frap. Exactly. I don't go to Starbucks much because of that. And also, I kind of prefer what I make at home. So Not that our K-Cups are saving us a ton of money because there's a lot of people in our house, and we go through a lot of K-Cups. You don't do Starbucks? I just don't find I find now I don't know, I just don't care for it. I don't care for it as much. I mean, if we go there, I'll order some stuff, but, like, for me, no coffee at all? Oh my. Mm. I'm not sure we can be friends anymore. But you do like fish mango, cream, so, we're on the same wavelength. Coke and tea. I was a Coke girl too. I was actually a Coke Zero girl, 2 Coke Zeros a day, one in the before lunch and one after lunch until I realized that my migraines and persistent headaches were related to the Coke Zeros. So, Mr. Midwife's Folgers and black silk kind of oh my, you're the OG. You're the OG. Do you do it like black, black? Probably no sugar, no cream, right? Excuse me. Excuse me. Scott said he did not 100% endorse so you didn't like it? I mean, I wouldn't say it's, like, delightful, but if you gotta take fish oil, cream, no sugar. Okay. All right, Mr. Midwife. All right. All right. I prefer, my coffee like myself, blonde and sweet, which is partly why intermittent fasting was so hard for me because I can't do black coffee ever. It wasn't yummy. I don't know. Oh, it's definitely not. I mean, I say yummy in regards to it's yummier than burping up fish oil, like the capsules that you take for 3 hours. Mr. Midwife is over this. He's so tired of us talking about this fish oil. I don't know why it's made okay, so for everybody else, I keep usually this video is done while I'm getting ready for night shift and putting on makeup, and right next to my sink, I keep this fish oil, like, liquid that a friend of mine told me about, and I always wanna take fish oil. I know it's good for you, but I can't stand even putting the fish oil in the problem is if you put fish oil in the freezer, like the capsules, it'll, start to break down lower down in your GI tract, so you won't do all the burpy stuff, but then you gotta remember to go get it out of the freezer, which I'm not gonna do. So, anyways, she told me about this, who makes it? I think it's Barleans, and they make this fish oil or it's fish oil cream, and it comes in all these different flavors, and I've got mango, and I don't even measure it. I just put it there, and when I'm putting on my makeup, I take a swig of it and call it a day, and I feel healthier about that. I mean, you know what? That that compensates for the bad knee that I'm ignoring. I'm taking my fish oil, but I like it because it makes me happier than burping up fish oil for hours, so but Scott, did pick some up because I recommended it, and Mr. Midwife gave us the vomit emoji when we talked about it. Bree has unusual powers of persuasion over me. She flashed a bottle of mango flavored something good for you juice. Yeah. Yeah. It's because, I like to share things I like. Because I love that too. My favorite Facebook post from friends when I scroll is like, hey, I got this new product. I'm like, really? What'd you get? I need it too. So I like to share that kind of stuff. Um, yeah. Okay. I don't know. I don't have anything else to monologue on. Nothing else really happening here. I am looking at a stack of printed out books because I finally finished my second book that I've got to actually produce and put into a book, like bind it up and all that. I've kind of been holding out because one of the things that my accountant said was to make my daughter a 1099 employee and pay her, which is what I did before. But I'm at the mercy of her college schedule and when she feels like helping. It's the joy of having young adults. They're like, Mom, I need money. I need money. But yet, oh, when I come home, I don't really want to do this. Like, okay, well, help me help you, child. Help me help you. We'll talk skin. We do talk skincare. We do because I have rosacea. So it's always a topic of conversation, which my rosacea is getting better. I mean, it's definitely better. I'm definitely less dry. I have a new dermatologist and she put me on a whole bunch of things that we'll see. We'll see. It's working out so far. And of course, we always talk makeup. All right. I don't guess I have much else, but I appreciate y'all for, jumping on here as always. I look forward to this week, even if I am exhausted and not saying super smart things. You need some anti-aging products like creams, or the anti-aging products I'm recommending these days are Botox and fillers. I'm a recent convert. I got Botox for the first time in February, it was last month, and actually, the plastic surgeon did it. It was not an injector, and she was talking to me about my plans or whatnot. I was like, "I don't know, I kinda want, like, to fill this in," and she was like, "Well, I'll give you some Botox." I'm like, "I don't know about Botox." She called me a Botox virgin. I know there was such a thing, but she broke my cherry, and there's probably no going back now. It really helped, like, the crow's feet here. That I don't have much up here, although she did put some here, but I have a lot of resting crow's feet. That's where you see my age, that and here. But, yeah, so because that's gone, I'm like, "Oh my gosh, she just took" that, and I got a little bit of filler here, so it fills in. I have super dark circles, which is genetic, and I've had them since I was a child and well rested. But it's way, way better. So I look just less tired, even though I've slept 6 hours in 3 days. You can't tell. Or maybe you can. Either way, it's way better than what it would look like without it. So I'm definitely a fan of that. Um, Laser resurfacing, I haven't looked into it, but I do think that would be great, particularly for I wonder about it. I'm super fair, so I wonder how fair skin would handle it, but I do have dark spots, and I had acne when I was a kid, so there are some things I wouldn't mind, like, yeah, smoothing out like that. Sun damage and age spot. Yeah, that's what I got to you. I've got a couple of them. What's interesting is that it covers up very well with makeup, but without makeup, I can see it, but nobody else can see it. It's, putting our best face forward, trying not to age here physically. um, yeah, yeah. Just means you spent a lot of time out in that good vitamin D when you were younger. All right, I think I'm going to jump off now. Next week, again, planning to talk about decision fatigue, which isn't maybe a super heavy topic. So possibly I'll add something clinical on the back end of that. We'll see. As always, if you have any thoughts or anything you want to learn about, by all means, let me know. Mr. Midwife says he's one giant age spot. I know, just running to stay ahead of things. An old fart. I love that. I like it when people put emoji interpretation in words for me. All right, y'all have a lovely week, and I will catch up with you next Thursday. Bye, everybody. Good to see you.